all the way into the slide. So a bit of background about myself. I'm an osteopath in Australia. I've been treating since 2006. I've had my own practice since 2010. I was first introduced to Shock Wave in 2013, where I was introduced to the Swiss dollar cast system, and then after that, Swords MD200. Basically, I didn't find any success using either of those technologies, and that was just because of the lack of training that they provided. So I started looking for another unit and researching Shock Wave and seeing what else was there. Basically, back in 2017, when I first stumbled across the Modus ESWT, back then I was over in the US working with Australian basketball, Matthew Dellavedova, who had a patella tendonitis issue. So we chose to find another way to help aid his condition, and we went on with the Modus ESWT for that. So from then on, I started working with Inceler and trying to basically introduce Shock Wave to the Australian public in my area. And from that, we've had patients come in from all sporting fields to be exposed to the Modus unit that we've used, and I've introduced the basically focused Shock Wave rating now in my clinic. So the principle of Shock Wave therapy is the next thing we need to sort of understand before we start using it. So basically, with the focused shock wave, we've got three forms of delivery methods. One's electrohydraulic, which is what Neil looks like. So there are the three basic principles, which is electrohydraulic, which Inceler Focus uses, which is basically electrode in water, which creates a spark, which causes the shock wave to develop. You've got electromagnetic, which is generated by electromagnetic coils, forces to create the sound wave. Then you piezoelectric, which has got several crystals in a sphere, which then are charged to create the sound wave. Then the next applicator is our radial, which we use a pneumatic compressor to push a little bullet to hit the applicator tip, where the energy is shot out from the applicator, creating the sound wave. And that can be done through pneumatic or electromagnetic. Inside we use the pneumatic, which is shown to be quite effective, I think, also from the electromagnetic radial wave. Then we get the biological effects of the shock wave, which is basically we're getting regeneration occurring through angiogenesis, which is new vessel formations. We get the recruitment of progenitor cells, which will help form new blood vessels, helps with the inflammation response, and basically we get pain reduction, which is hypothesized to be caused by the reduction in the release of substance P. And all this is caused by mechanical forces to the cell, which is created by the environment mechanical response. Now, the Modus unit, which I use in practice and most of us are trying to sell, the importance of it is that it operates with 1 to 5 bars of pressure, 1 to 22 hertz. The handpiece will have 3 million shots, and you've got a different comfort metal modes with treatment. The hertz and the bar pressure is important because we have a basic guide that we use in order to gain our treatment efficiency and effectiveness. So there are other units out there which have a restriction. So we're lucky that our Modus ESWT, the compressor works, the bar pressure independent with the hertz. And then we have our Modus, the focus unit. We've got the shock rate from the 0.1 to 0.25, 1 to 4 hertz, and the ability that we've got a wider treatment zone, which is of more effectiveness I found compared to the other units out there. where with the other units you have to pinpoint on the area that you're treating in order to get an effect. The indications with, next we've got the applicator heads that the units both have. The applicator heads are important when we're trying to decide what we're trying to treat, how deep the structure is, and how sensitive the patient is. So we've got a really sensitive patient with a radial unit, we want to use the wider applicator head, because the sound wave disperses wider range, making it less uncomfortable for the patient. We've then got the indications for shockwave therapy, uses in our clinic, so chronic tendinopathies, bursitis, osteoarthritis, your lateral medial condylitis, plantar fasciitis, lymphedema, Sever's disease, one of the more common stuff that we'll use it for with the radial unit. Focus can be used on all of these as well, along with treating stress fractures and your wound care and your calcified tendinitises. A lot of practitioners will get told you can use the radial device with calcified tendinitises. However, that will just help ease the symptoms and also then help break down that calcium that's in the tendon. And then the main contraindications that we have that we need to be mindful of is that with the radial unit, it's mainly just malignant tumours, fetus in the area, and also if they have a pacemaker around the treatment area. Your focus units have greater amounts of contraindications that we have to be mindful of. That is an epithelial plate in the treatment area, obviously the brain or spine. Your absolute contraindications are your lung tissue, severe, someone's on anticoagulant medication, again, tumours, a fetus in the treatment area, or a pacemaker defibrillator around the treatment area. So then, basically, we'll be doing a practical demonstration, but we also have some basic principles that I use when applying shockwave therapy. So, according to our International Shockwave Society, the therapeutic treatment range is between 8 to 12 Hz of frequency. And basically the bar pressure aspect, it's normally between 2 Hz and 2 bars and up. When I start a treatment, I'll tend to treat a patient at 500 shots burst at about 10 Hz at 1.5 bars. And that's used to gauge the patient's tolerability of shockwave and also how sensitive they are. And then while we're doing that, we'll slowly lift the bar pressure up within their comfort range. And then once we know where they're comfortable, we'll produce another 2,000 shots around the area there. When we can focus, I'll usually use 4 Hz on all conditions and start at a 0.1 output and then work either side of that 0.1 within the patient's comfort range between 1,000 to 2,000 shots. I'll commonly combine radial and focus shockwave together in treatment, and that's purely because I'll use the radial unit around the muscular areas, not a point and shoot delivery like a lot of practitioners have quite often shown. And most patients' treatment sessions will be, they'll need between 4 to 6 treatments, about 4 days apart minimum. I wouldn't do it with close-up. And however, as much as shockwaves recommended for chronic conditions, we use it a lot I use it a lot in clinical acute as well. A lot of those patients will respond quite quickly. Often after 1 to 2 treatments, they'll find that the issue is resolved. And another important one is that we use it on is joint degeneration disease, so joint degenerative disease, in particular osteoarthritis of the knee. A lot of patients in Australia wait for a knee replacement up to 2 years, and I'll use shockwave as a way to manage their discomfort and pain. In regards to a lot of those individuals who have issues sleeping at night, they need pain medication, and I found using the shockwave therapy, we're able to manage those pain levels at night and reduce their medication use. Lastly, as well, with shockwave, when using it, it tends to be the patient's adjunct therapy, so we don't use it as a primary form of treatment. We'll incorporate rehab exercises with it after it. We may also do some dry needling therapy to aid as well, but quite often it will be shockwave, rehab exercise, help load the tendon, and then the recovery process will commence and also help speed it up. So on these images here, this was using a radial unit on a patient with torn rotator cuff tendon who's waiting surgery. He had issues lifting his hand above his head to put the top on. Initially had 80 degrees of abduction in his arm. After radial treatment, we were able to get it to 90. And then we did a focus session on it. Straight after it, we were able to get an extra 5 degrees of movement. So we got him up to 95 at the end, and he was able to dress himself without aid after treatment. So what we'll also plan to do part of the steps of this talk was to do a demonstration of using radial on focus shock wave on a patient. So I'll put it out there as any delegate who would like to come up and be a patient for it. We'll go with Tom there. So get you to come up. You're welcome to come around the table to get a closer look of what we're treating Tom for his injury. The other thing that I've also forgot to mention, the important part when treating shock wave therapy is the diagnosis aspect of the injury. A lot of you may get some practitioners stating that they never got a result with shock wave therapy. That can quite often be caused due to the lack of diagnostic tools from the practitioner. So you may have someone who's getting pain shooting down around the knee area. The practitioner's treating the knee, they're not getting resolved. The pain could be coming from their lower back, so they're treating the wrong area, hence they won't get a clinical outcome. If you like, you can come forward and come around to watch us work with Tom here. Yeah. Alright, so first we're going to do just a quick assessment for Tom's Achilles, so just walk up and down a little bit so we can see. Just around. Stand up on the toes, so we see with our toes. Any pain on that? We'll go on a lunge. Yeah. Single leg, so we stand on one leg, we start on the toes, right, and then the left. You pain on that? A little bit on that, yeah. Alright, so we get you onto your stomach, Tom. Face down. That's all right. Yeah, right back there. If you want, someone's had a build. Just I'll say squeeze over there. Looks like we can do a thickness in there. And then come over into this arm, do the difference between there and there. Oh, thank you. And what I'll do with the Achilles tendonitis, we'll start with, that's right. We'll start with using the radial shock wave unit. I'm actually going to work okay, so we're just going to work through the actual Achilles tendon from the mid up into his calf, up and down to try to loosen the muscles in the area, reduce some of the inflammation. Then we'll move on to using the focus unit around the Achilles tendon. So we always have to apply some conductor gel first. And for this, I'll use a wider applicator head. And the reason for that is to try and work through the superficial layers of the muscle. So Tom, let me know if it's something afterward any time. Yeah, so about a 7 out of 10 is what we're looking for. If there's discomfort with this one, you shouldn't get a lot. You should just feel a bit of a zapping sensation in the area. Like that. So as soon as Tom is going to couple, we'll put the bar pressure up. Like that. Like that there. Are you feeling that little zapping sensation? Yeah. Feel comfortable? Yeah. That's comfortable there. Like that. Quite uncomfortable. Alright, so we'll leave that back. That's 4.5 bars. So we're going to find with the hand feet, just take up a little bit of pressure in the tissues. You can get, you don't get too hard with the hand feet. That's uncomfortable. Let's hear it close. That's that way. So now that we've used the radial unit, we now get the focus out. And you can already feel that it has that position on that. You can just have on that. How's that feel?
Yeah.
You definitely feel the difference between the two now. Yes. Alright, so now we've used the focus unit. We're going to focus or put the shock waves through the Achilles tendon. Now we don't need to move the focus unit around while treating. So I'll set it to 4 Hertz. Oh yeah. Yes, turn it out. So we do about 1,500 shots on the Achilles tendon. So again, if no is uncomfortable. How's that? How's that there? Feel fine. How's that? You feeling? Yeah, should be most patients might find the focus uncomfortable. So if I'm radial more uncomfortable than how's that? Not at all. Feel fine. On this list on all the columns is here. You can feel it. You can hear it.
now we'll reassess. How's that one? This one. So Tom's just going to describe what he's feeling now in the area.
Actually, we would like to see it's just an outline.
So definitely less pain when you're squeezing the actual tendon itself, and it feels definitely looser, I guess. On the muscle.
Okay, so we'll get you to stand up. We'll get you to do that lunge again. Just lunge forward. Stand up on the Achilles. Yeah. Much better. The single here. So just a bit of a walk again, because last time when you were walking, you were sort of avoiding it. Yeah. Less tension, less discomfort. So we typically follow this up in 4 days time, treat it again. And in practice, I'll also give Tom some strengthening exercises for his calf and the Achilles, and maybe but yeah, that's basically how we'll treat the radial and focus unit together in conjunction. We can use it for regenerative knees, and we're different again. Yes. Last question, yeah.
So when you were treating, it felt like you moved both the devices around quite a lot. Are you doing that by general feel, or are you obviously the presets on the device don't tell you where to treat, so how are you deciding where you treat it when?
So with the first unit, I was targeting the muscles and the structures around it. We're using the white head to release those. That's why we're going up and down the muscle belly and tendon. With the Achilles tendon aspect, the inflammation around the Achilles tendon can either come from the bursa or the tendon itself. So we're working on each side of the tendon and on top of the tendon to target each aspect of it to rule out what could be causing it. Ideally, to get a clear diagnosis, we can ultrasound the tendon, work out where it's coming from, and then determine which
Where you do it, or you changing it based
I'll change the based on the field as well, not the patient comes reporting. If we have an ultrasound showing the diagnosis, we'll then work according to that first. Any other questions? All good. Right, thank you. Thanks, Tom. One more.
I'm working in a country in Africa, in 2 countries where there is no skills, neither for any kind of shock wave. I see the doctor might be interested, but they will say how to make treatment. Like do you advise a book who explain in details what you did? Because they will not know, and we will not know what to do. We don't have the vocabulary as well. For our neurologists, it's quite easy. I've been trained 2 times, I've been 2 times here to be trained for ED. But for physiotherapists and orthopedists who can, I think some of them can afford it. I need to go with a clear protocol for every disease. Just to let it for me, how we felt.
So a lot of it is the preset protocols in the units already, which can be a basic guide for the practitioner. As they use it more, they'll learn to adjust to make it work for themselves. And when it comes to so I found in practice, once we introduce it, a lot of the practitioners and patient base will build quickly. They will get results out of it. Once they use it, as Tom was saying, give them that time to trial that unit, they'll see the results. I've found a lot of practitioners that have used it and had it on trial don't really give the units back because they are getting those results. And a lot of them use just the basic protocol that are on the unit.
And for you, the basic protocol would be enough for most of them to understand?
For most of them, that's one of the biggest things I'll try to explain to practitioners. The protocol is there, but we want to keep, that's why earlier this is our therapeutic range between 2 Some individuals, the higher you use that frequency, the less of a result they'll get from the treatment. I had a chiropractor in Sydney not long ago using another device and was getting no results. And I said to him, look, what frequency you were using, 15 hertz? I said, he dropped the frequency down and he started to get results in his treatment from that. And now he's trialling, for example, one of the focus students at the moment, particularly that. That's the best way to explain it to a practitioner when you're using it. Then you can go a simpler shoot, point and shoot with the unit. If they don't want to move the handpiece around, like I can say the patient get uncomfortable if you hold them in one spot. So we want to move that unit to it and away. We're using the radial device. Focus you want to be more close to the spot of this function or full shoot.
Thank you.
Do you always suggest a combination of both therapies?
Yeah.
Sorry. Do you suggest to combine both technologies, radial and focus, relaxation of muscles, and then go to harder forms, tendons or whatever?
Yes, I tend to recommend both. However, one of the issues you may get from potential customers, they can't afford both. So if they use the radial, they can do a similar method, but use a wide head to treat more superficial, and then go to more narrower heads to hit the main spot you're trying to focus on a second round of treatment.
So upper and down limbs doesn't matter.
No.
Legs, arms.
So yes, it's a shoulder, we'll work through the rotator cuff tendons and then over the dorsal area and hold it.
Yes, for the country with limited budget, finally, so you can say that the radial of the job equals huge difference of price.
There is. So the majority of practitioners who can't afford, a lot of them you find they'll start with the radial, and then they'll want to go further and they'll go on higher focus unit. Because they'll get to one point and they think you need to do more, and they'll then want to jump to a focus. But at the beginning, it's a good starting point for a practitioner, and then they'll work up.
But the final orthopedist, the final result.
Yeah.
The final result with radial. So
You can't get the results for radial, not. You get a quicker result with the focus unit and a better result in a shorter period as with using the focus, also the radial. But as a starting point, if they can't afford, radial is often the starting point.
okay, thank you.
Thank you so much.
Thank you.